right, so let's talk about ACS a little bit. Acute coronary syndrome. Guys, this is nothing but a big word for saying our heart problems. This is some of the new stuff coming out. They all start defining things as ACS. Every year, an estimated 185,000 people have a new MI in the United States alone. That's approximately every minute one American has succumbed to ACS or heart condition, cardiac condition. So this is a big part of our business, as you can see. And I mean, how many chest pain calls have you wrote this week? You know, several. And so this is something very big. So as far as for the educational purpose, this will be for the state certified folks. This is 1 hour for medical. Or for the National Registry folks, this is airway, breathing, and circulation 1 hour. So we've kind of got it broke down for you, and I'll get that put in on your stuff. So some of the objectives today is, first of all, we want to define what ACS is, talk about angina, talk about STEMIs and non-STEMI ST segment MIs. We want to learn about the typical and atypical signs of ACS. We're going to understand a cause of abnormal 12 leads. We also want to talk about some of the pharmaceutical changes that we're going to have, and Dr. Troutman's going to touch on that. Because guys, starting after tonight, well, I say starting after tonight, we're in the process of doing a protocol change. Once everybody gets this CE, we'll be doing a protocol change with the way we take care of our chest pain patients. And we also want to talk about, we want to review this recent chart from our service that is the chest pain call. Guys, it's kind of hard for me to pull chest pain calls because we have so many of them. It's such a big part of our business, it's hard to kind of pick and choose these. So first of all, let's just define this. This is a broad definition for a group of conditions, not just one. This talks about, basically at the end of the day, decreased blood flow through our coronary arteries. That's what ACS stands for. Whether this may be from plaque buildup, or whether it may be from narrowing of the arteries, or all the way up into a coronary spasm. ACS is defined as these things. So we talk about I knew I was going to not be able to say it. Arteriosclerosis. We start talking about the primary cause. This is the number one thing. Guys, is what this is over the years, and this is something that starts when we're very early in our life. But we start to get a little bit of a plaque buildup, or we start to get narrowing of our arteries, and then on top of that we put a little bit of plaque on top of it, and then as you can see over time, my body says, hey, I've got a foreign body in here, and I've got to do something with it, so I start to put calcium on top of it. And y'all remember the EBT test that came out many years ago and talked about, it gives you a percentage of the chance of you having a heart attack. EBT is what it did. It read nothing but calcium buildup. And so until about the age of 40, we really don't start to build calcium. Once we hit about the age of 40, we start to build that to protect those cholesterols. And Brendan shaking his head like we're to that age, so we're finally making it over the hill. You younger folks, y'all don't have the calcium buildup yet. But guys, this talks about, this is the early stages, and this is the more advanced stages. As you can see, I've got a buildup here, and you can see my little plasma cells trying to slip by, and it just gets narrower and narrower until we finally can't make that happen any longer. As we talk about, early clogging starts very early. It starts from when we're young. One of the biggest factors of this is my genetics. Okay? Some of the literature suggests up to 80% of this deals with your genetical cycle versus 20% of food. Where that really stands at the end of the day, we're still not for sure on that. The things that contribute to early clogging of my arteries is hypertension, smoking, diabetes, and high cholesterol in my hamburgers that I'm eating every day. So this becomes now, what's our typical EMS diet? Fast food. Things that I'm going to be grabbing on the go, and that contributes to my high cholesterol. Well, if my mom and dad and my grandparents had high cholesterol, you're probably going to be susceptible to that. So that piggybacks onto that extra cheeseburgers that I'm eating. And so instead of eating that triple meat, triple cheese, maybe I need to stick with just my singles. But I won't.
Compromise with the double.
That boy, okay. And an extra Crestor. That'll work. So not all patients that suffer from ACS have the plaque buildup at the clogging arteries. Some way we talk about the squeeze. We talk about spasms that may happen in the coronary arteries, things like cocaine, methamphetamine use. Stress induces this. And then we have, she did this to me on purpose. Prinzmetal, go ahead. Prinzmetal angina and Kunis syndrome. And we're going to break these down a little bit more. Some of this being some of the new things. But guys, cocaine is a big thing. Cocaine is coming back hot and heavy. It's getting cheaper to buy. So we're seeing these folks with the coronary spasms from that. On top of coronary spasm, it may be the patient that just left the hospital from getting a stent placed, and then they start to have coronary spasm from the irritation in the coronaries. So that can cause a lot of our ACS. So as we talked about the anginal side of this, this is something that usually occurs at rest. This is where the inner lining of the vessels, actually from an adrenergic effect, will actually narrow from that. And it's a direct response from our epinephrine. So if I'm at rest and all of a sudden something scares me, I have a big dump of epinephrine, that could cause that to narrow and spasm. On the syndrome side, and you notice I'm not trying to say those again, I'm not going to butcher that again. This is basically some of the new things that came out in 1991 talking about an allergic MI. So during an allergic reaction, I may have a quick dump of my histamines, and that may cause this, it may trigger those vasospasms in my heart. At the end of the day, does it matter? It doesn't. If they're having chest pain, it's caused from something either closing or a plaque in there, and so I'm going to treat it the same at the end of the day. And we're going to talk about that more coming up. So more definitions. We talk about ACS. We have a STEMI. We all have a STEMI protocol. And so we try to limit our scene time to 10 minutes or 15 minutes on scene. We try to expedite and get off the scene quickly with these folks. STEMI stands for the ST segment elevation myocardial infarction. On the non-STEMI side, or that's the non-ST segment myocardial infarction. So this may be over in that 12 lead, and they're having crushing chest pain, they're diaphoretic, they're nauseated, but I'm not seeing anything on my 12 lead. This is where we refer to our ST segment, but it has some more factors. And then we have our unstable angina. And this is just that patient that, you know, that you're picking them up maybe weekly, every other week, have to 2 nitroglycerin, really didn't go away, need to be transported to the hospital now. And you're not really seeing a lot on 12 lead. So how will I know the difference? A lot of times these things are diagnosed by a couple of different items. We have 12 lead, first of all. That's our number one go-to. In fact, 12 lead became so important to us 6 years ago that we made the ability where we can transmit that from their house to where they can start making decisions at the hospital. So 12 lead's a big one. Next is our cardiac markers. You're going to see that primarily by troponin I. We say this because a lot of times you go to a clinic and you're picking up somebody with a chest pain and they hand you a lab sheet and it's got a troponin on there. Now you can start adding 1 and 2 together and figure out what's going on with these folks. So as we break this down, first of all, we want to acquire a 12 lead and lab values if possible. That's why it's important for us to draw those labs on scene so we can go ahead as soon as we get to the hospital and expedite that process of getting labs going quickly. Just like we do with stroke. They need to get a PT, a PTT, and an INR. They're going to get all the cardiac enzymes. You're going to be looking for a CK, a CKMB, and a troponin. They're going to start moving forward with this quickly. So we start looking about, do we have ST segment changes? If I have 2 or more ST segment elevations in contiguous leads, I'm kind of leaning back toward my ST elevation MI, my STEMI. At that time, they're going to be looking for an elevated troponin. But if troponin remains normal, I may need to consider another dose. Do I have a heart infection? Do I have something else going on with the body that could be causing me, or a bundle branch block, or something else that may be causing this to look? But if there's an elevated troponin, we have 1 and 2 together, this is where we get our STEMI. Dr. Troutman, do y'all activate off the 12 lead alone, or is it always lab value with it?
No, so the definition of a STEMI, an ST elevation MI, is based purely on an EKG.
Okay.
And in STEMI, a non-ST elevation MI, which would imply non-ST elevation, right? So a normal EKG, no ST segment changes, but accompanied with an elevated troponin is treated differently. They don't go to the cath lab acutely. They're usually started on like an IV to A3B inhibitor, and they probably are going to go to cath lab, but it's usually 12 to 24 hours later.
Okay. So on the other side, if we have only one or no ST segment, now guys, I said there's only one ST segment. That can be considered a non-STEMI. This is where they're going to check their troponin, and then we're going to have a non-STEMI. If the troponin remains normal and the 12 lead remains normal, this is where we get our unstable angina. Now guys, in the field, at the end of the day, chest pain is chest pain to us, correct? And chest pain is considered an MI until proven otherwise, and this is how they prove that otherwise at the hospital. But be educated to know when you're going to some of these clinics.
Well, and just another thing I'll add about troponin. Troponin is a great tool, but right now, if I am having a heart attack, and let's say I have a STEMI and you're drawing my blood, my troponin is going to be normal. So it takes about 8 to 12 hours at the earliest to start to see a rise. So, sometimes we see patients that have been having chest pain for 2 days, and that's where a lot of times in the ER we get a normal EKG, we get a troponin, it's undetectable, it's probably not ACS. But if they were mowing their yard 2 hours ago, started having chest pain, and eat a normal EKG, one troponin tells me absolutely nothing, because they may be an in-STEMI, and that's where you'll see we'll admit those patients or keep them in our OBS unit over there and get serial troponins. And also troponin can get difficult with renal patients or just renal insufficiency, because when your kidneys don't work as well, your troponin, because we all have troponin that comes out of our heart, it's just most of us have tiny bits and we just kind of pee it out, but when you don't pee so well, some of that can build up. So then you get this false positive. Okay, they're a renal patient, they had chest pain, their troponin's elevated, are they an in-STEMI or are they not? That's where it gets complicated on making a decision on what to do with those folks.
And we're going to talk about troponin more in just a little bit. So we talk about some of the atypical signs. Guys, ACS is not always chest pain. We got to start looking at differential diagnosis. That's why we start looking at those things like, sorry, wrong button. We start looking at our older patients or our women. They're going to have a unique presentation a lot of times. It may not be chest pain, maybe just jaw or a fullness feeling in their throat. We also talk about diabetics, and we talk about our heart failure patients. A study of over 430,000 myocardial infarctions, only 66% of them had chest pain. 66%. So 33% of them had no signs of typical sign of my chest hurts and I have chest pain. But what they were seeing was dyspnea, fatigue, nausea, dizziness. Well, guys, if they're dizzy, a lot of times they may fall. That's why we're seeing our crews be very aggressive with, okay, I got to fall, let's get them in the truck, let's run a 12 lead. We see that every day of good practices like that because they're finding those differential diagnoses. We talk about our diabetics. Cardiovascular morbidity is the main cause of death in our diabetic patients. The inner lining will stay inflamed from the diabetic, from elevated blood sugars. So if their AC13 may be elevated, to 8 or 10, maybe something, they may be a chronic diabetic patient. Well, they may have chronic inflammation in their coronaries all the time. So that's why we may not see them present with that chest pain. Diabetics have a 2 to 3 times greater risk of suffering a cardiovascular event than a regular patient will. So that's very, very important for us to take into effect. But not only our diabetic patients, but we also start talking about our HIV patients, our autoimmune disorders. So anybody that may have an autoimmune dysfunction, whether they be on chemotherapy from cancer, this can cause that to remain elevated or inflamed in there at all times, which is going to be natural closing of those coronaries. So these patients may present with just that dyspnea, that nausea, vomiting, that sweatiness, but not necessarily always have the chest pain. So a 12 lead. Since 33% of our patients, we just talked about this, may not feel chest pain, 12 leads should be the number one cause, some of the number one factors of things we key off on dizziness, on weakness, on general falls with our elderly patients, nausea, vomiting. If I've even got a female with complaining of high abdominal pain, she's probably going to get a 12 lead. And the reason is those females are going to have that unique presentation that not everybody's going to have, or maybe our diabetic patients. So let's go to a basic 12 lead review real quick. Remember that our limb leads, guys, when I say limb leads, these need to be out on the limbs. This is a positive and negative effect. My lead 1, I'm looking from my right side over to my left. On my lead 2, I'm working from my left down to my right foot. My right hand to my left foot. And then lead 3, I'm looking at that lateral view of my heart. So I'm looking at the left side going down to my left leg. My augmented leads, remember these become very important to us. Our ABF, our ABL, and our AVR. This is what we refer to as our quick 6. And so a lot of times I'm able to take a quick 6, and I'm able to take a quick view of the very front portion of the heart, or the septal view of the heart, moving into the right side. My precordial leads, remember, it's using the heart as the negative, coming out to the positive of my V1, V2, V3, V4, V5, and V6. Placement is very, very important here. So I make sure that I'm looking at my septal leads right here. I'm moving into my my inferior leads and then my lateral leads. So I need to make sure that I have my leads in the correct position in order to get the view that I need. As we look about our coronary arteries, this is why we're looking at the things we're looking at. We're looking at lead 1 and lead 2. We're looking at a straight shot right here. As we move around, we want to make sure that we're able to see these. Remember that our big vessels on the outside is what feeds the outside of our heart. As these vessels get smaller, they start to embed into the muscle, and so I may only have a booger or a big clot right down here, which is going to give me just that portion of my heart. Versus if I have something with a big LED blockage way up high, I'm going to sure cause a lot of problems, because then I've got everything affected. Now, the nice thing is, as we get older in life, at about the age of 50, we start to build our collateral vessels. And this is where our older folks get the spare or the extra little vessels everywhere, and these will actually start to connect from time to time to the right and left side. So if I have a big booger way up high, I may get some feed from my right side coming across. And so it's something that those older folks sometimes will typically do a little bit better. At the same time, remember our plaque buildup or our clogs is going to, where it's blocked off, I'm going to be distally that. Because we're going to be without oxygen. That's where we start talking about our infarcts. Excuse me. So we start talking about our myocardial infarcts. All you're seeing here is electrical conduction. Remember, I see that ST segment delay through there. All I'm seeing is that energy, that electricity not being able to get through the dead muscle. So that's why I have that elevation. On the same side, if I have my depression, it's saying, hey, way over there, I see that you're having problems, and it takes a long time to get through that. That's all you're seeing is the electrical portion of that. So we talk about the 3 stages of our myocardial disease process. We talk about ischemia. This is an early and potentially reversible cause at this point. And if I'm aggressive with these patients, I may get there and say, well, I don't see a lot on that 12 lead. Be aggressive with them, because they're in the early stages, and if I can prevent them from escalating to an injury stage, this occurs later. This is the myocardial, maybe somewhat salvageable around the edges, but probably not into the main area. And last but not least is infarct, which means totally death of the cell, and that's where the myocardial, it cannot be saved at this point, and it is dead. So as we put it into a little bit more of a visual for us, we have our normal ST segments that are probably going to be looking now. This is going to be ST elevation. This is ST depression side. So as we move into ischemia, guys, how many times have you seen a 12 lead and that T wave really starts to stretch out? That's an ischemic heart. You may not have any elevation yet, but that's telling me I'm stretching, I'm trying, because that electrical pathway is taking longer to get through there. So I'm seeing ischemia at that point. As I move down on the ST segment side, this is where I get my ST inversion. It says, yes, I'm recognizing I do have an issue, and I've got a negative deflection at that point, and I'm starting to progress down. As we move into the injury pattern, this is where we start to really stretch, or we even start to get ST segment elevation. And as we move into infarct, that's where we move into our tombstone, and we see the full elevation. At the same time, in our what we call our reciprocal leads, I'm going to see that on the opposite side, and I'm going to be able to see that, hey, yes, I'm confirming I do have an injury pattern here. Excuse me. So this is some just a breakdown. This is a hyperacute T wave. This is what we're talking about. I see lots of 12 leads with not real aggressive medicine done for just a simple hyperacute T wave. This is where you're starting to see some, man, that T wave looks funny. That's because I'm starting to get a deoxygenation pattern there. I need to add a potent vasodilatator in here, IER nitro, so I can be able to extend this before I can fix this before I extend down into an MI. This is something that we're probably not just super great with recognizing, because we see that from time to time. We go, well, I really don't see much on the 12 lead. Be sensitive to that ST segment, and then it's starting to show you that it's hyperactive at that point. What they consider hyperactive is anything that's 2/3 of the height of the QRS complex. So this becomes very... Now, what else is important with our QRS complex on the 12 lead? Our wave progression. And so we need to make sure that these are in the right spot so I'm able to gauge what's going on. That's on the ischemia side. On the reverse side, this is going to be my ST depression. This is going to be insufficiency of my repolarization at this point. And this is going to be mainly on the exterior portion of the muscle. So this is where I'm going to start seeing my ST depression. Then I'll move into my injury pattern. This is where I've got, once again, my full-blown ST segment changes. I'm going to have it on both sides and possibly some reciprocal changes. And remember, we're moving into death of the muscle. Guys, that is not repairable at this point. So what damage is done is damage is done. So I'm going to be very aggressive, opening these patients up very quickly. And we do a great job with being very aggressive with those nitroglycerin quickly. Moving in and then notifying the emergency room to get these patients to the cath lab. Once again, the injured heart showing the prolonged ST segment. You can also see that's the electricity. It's taking longer and longer for it to get through, and that's what you're seeing. And then, of course, the infarct, once again, very, very large pattern. So let's start a quick review on what we're looking at. Once again, we have our limb leads over here. So we've got our lateral pattern, we have our inferior pattern. This is our quick 6. This is what the things we're going to be looking at in that quick 6 area. Once I get a full 12 lead, remember I'm looking at the septum. This is why it's very important to have my leads in the right spot. I'm going to be looking right into the septal area. Lead V3, I'll move down, 4, 5, and 6 as we move around to the anterior and the lateral aspect of the heart. Very important. At the same time, we also see ABR. ABR should be a direct opposite of what my lead 2 looks like. Should be. And so I should be able to see that immediately and recognize that ABR that's the base of the septum right there. That's what I'm looking at. Not a lot of people recognize ABR in the pre-hospital world, but it's something that can be very important to tell us what lead 2 is doing because it should be a mirror image.
And if not,
Should be an upside down mirror.
Yeah, upside down mirror image.
and if not, that's where you start to worry about, did you mix up, you put 2 on V2 and V2 on lead 2 or what have you. Those don't look right.
This is what it's recognized when it says leads may be reversed.
Right.
That's what it's picking up. And then once again, as we move into our vertical leads, this is where we move around. I'm sorry, horizontal leads, this is where we start looking at, once again, our negative aspect coming back out to the heart. That's why it's very important to have our leads in the right spot. So you take a look at this quick 6. We see this all the time. See anything major? Anybody? ST segment changes? Depression? Maybe it's not a great quality. We're not really worried. But when we look at the whole kit and caboodle, what are we looking at here? A huge MI. So what this is telling me is I'm not seeing anything on my septal or my right side of my heart, but sure the left side is sure looking pretty nasty getting into a posterior. So the Quick 6 is a great tool to start looking at those things, to have the frontal, because what we worry about the frontal, the right sided MI, if we're going to give nitro or not. We really start kind of weighing that at that point. But that's just showing you that there can be a massive MI along with a clean Quick 6, or what we consider a clean Quick 6. Our wave progression becomes very important to us. Quick review. Remember, our lead 1 needs to be smaller than our lead 2. Our lead 3 needs to be a little bigger. 4, 5 needs to be our largest, and then 6 starting to trim back down. R-way progression is very important. Now, if I check this, my R-way progression, and I notice that I'm not getting bigger as I go across, this could be, and I know my leads are in the right spot, this can become a big thing because I may have an MI with a weak posterior wall. It could be a bundle branch block, left ventricular enlargement, old MI, tension pneumothoraces, Wolff-Parkinson's White. So guys, a lot of these things can play in, but that's why we've got to make absolute sure that those lead placement is proper to start with. I've got to have that R-way progression. Sometimes you may know, we had a lady the other day that, we try to displace the breast in order to get, when we put it on and we let the breast go, it actually folded back down, which gave us a very skewed view. That's something that you've got to weigh to make sure that my lead placement is correct. Once again, this is a reflection of moving the V2 only for 5 centimeters one way or the other. You can see the progression. This is where it should be right here. And you can see the progression of what you're looking at. My QRS complex here is very weak. I'm not getting a good look at my T-wave at all. As I progress and I move it up and then to the right and then up and to the left, you can definitely see, because now I'm looking at more of a ventricular look because I've moved down 5 centimeters and I'm getting more of a look at the ventricle instead of the septal wall. So it doesn't take a lot of movement in order to make a big difference on what I'm looking at. So I've got to make sure that I'm staying in the right spot. So pre-hospital treatment. First of all, we're going to break each of these down. We want to train serial 12 leads. Expedite transport, maximize our oxygen, get something on for our platelets on board, dilatate our vessels, and address the pain and ease the workload. So first of all, serial 12 leads. Guys, I can't stress this enough, and we've been pushing you guys to get your monitors in the house. If you show up on a category 10, take your monitor in. The quicker we can get these 12 leads is the quicker we can start making decisions. It's not uncommon for us sometimes to see a 12 lead at minute 12, minute 13 of the call. Well, if I go in the house, I get you loaded up, I move you to the truck, yeah, it's chest pain, I get you on the heart monitor. What about if I had that in the house? I'd make decisions a lot quicker with what I'm going to do. Serial 12 leads become important because it shows where did I start with this MI or my ACS and where am I headed to. And I'm not saying with aspirin you take one, with nitro you take one, but once you give your aspirin to nitro and a nitro, maybe take a second one. And then right before you get to the hospital, take a third, especially with your active MIs. Because it shows, am I growing? Did things I do help? Are things changing along the way with my MI? And so serial 12 leads become very important. Everybody's done a great job with their serial 12 leads. Expedite transport. Guys, we've learned a lot of things from trauma level 1. Let's get off the scene. They don't need a paramedic, they need a surgeon. Same concept with our cardiology, time is muscle. We want to make sure that we're off the scene quickly with these patients, 10, 15 minutes. If not, justify why. There's no reason why we couldn't get off the scene with these folks. I walk in, they're diaphoretic, they've got chest pain, I know something's going on. So let's get a 12 lead quickly, let's make a diagnosis, and let's get off the scene quickly. Maximize our oxygen, guys. By HA standards, we want to keep our oxygen level of 94 or better. Does that mean every patient needs a non-rebreather? Absolutely not. Absolutely not. Guys, most of the MIs that come in the hospital, I would venture to say that 90% of them get a nasal cannula and do just fine. Is that fair to say?
Absolutely, but then also remember, anybody that we are suspecting, chest pain and we're thinking this may be ACS, that even if their stats are 98%, we still should be putting on a couple liters nasal cannula. Again, it's just to decrease, it's a little less demand on the heart, a little more oxygenation in the bloodstream when it comes out.
So one of the clinical trials came out, 18 stable coronary heart disease patients administered 100% by non-rebreather, decreased coronary artery flow by 30% after 15 minutes is what they found. So guys, sometimes we give them too much. Go to a nasal cannula if they can tolerate it. If they're sat in 88%, I would probably still be comfortable with the nasal cannula at that point. Guys, if they're sat in 68%, maybe I need something a little bit more. And that's a judgment call that you get to make in the back of that truck, okay? Nasal cannula should always be considered for minimal flow. Prevent platelet aggregation. We want to make sure we get our aspirin on board. 325 or 481 milligram aspirin, 324 milligrams. We want to make sure that we get this. Guys, chewed is the way to go. Chewed actually showed in the study that it was 10 to 20 minutes versus swallowed was up to 30 minutes before you start to get platelet deaggregation. So we want to make sure that we're getting that chewed, give them a little sip of water, try to keep their tummy empty at all possible, get that aspirin on board as soon as possible. Patients also may be taking Coumadin or warfarin or other anticoagulants, Plavix, stuff like that at home. It is still recommended to go ahead and give an aspirin on the scene. Go ahead and be aggressive with those folks. Nitroglycerin, this is our primary fix. This is the only drug we carry that's going to give vasodilatation and open up those vessels. We need to make sure that we're aggressive with our nitroglycerin every 3 to 5 minutes. Okay? I would venture to say if it's an MI, I'd probably be more aggressive at 3-minute mark instead of 5-minute mark. Remember, just got to watch our blood pressures, make sure blood pressure stays above 90. We want to make sure that also a lot of times, guys, remember with our right-sided MIs, if they're bradycardic, I've got to be really careful with this nitroglycerin thing because I've got a pump demand at that point. My preload is being shot because remember our SA node is fed by an artery, our SA artery coming off the heart. So if I have a high right-sided occlusion in the RCA, in the right coronary artery, that can affect that SA artery, and then I'm going to be in trouble because they're going to get bradycardic on me. Okay, so remember those right-sided MRIs. I got to be careful with my nitroglycerin from time to time. Address the chest pain and cardiac workload. Decrease their pain. Pain drives blood pressure. Pain drives heart rate. Heart rate requires oxygen demand. So we've got to take care of their pain. At the same time, we carry narcotics for an opiate in order to help knock the edge off for that. More than anything, at the end of the day, that's what our narcotics do for us, is knock the edge off of these patients and help get that pain reduced. Common sense is if I have an ischemic stroke now, I don't want that heart working harder. Let's take care of it early. Let's be aggressive with our narcotics here and get their pain taken care of to help that workload drop. That's all you.
All right, I'll try to speak up. So we're going to talk a little bit about morphine. We're going to essentially stop using morphine for ACS. So, sorry, I'm going to kind of have to read from these are the slides Chad put together. So everybody knows morphine's opiate. We've kind of used it a long time for ACS, right? There has been a thought that it kind of interacts with mast cells to release histamine, cause a little vasodilation. It's very minimally, probably, if it truly does that. Certainly not as well as nitroglycerin, which is a direct vasodilator. So we get a lot of vasodilatation with nitro. Increased risk for nausea, plus people itch with morphine. Not a big deal. You know, we can maybe give it with some Zofran and kind of counteract that. So not a huge deal. This is probably the big reason why people are starting to rethink morphine for patients with ACS. So we've talked about aspirin's really important, and then these Plavix, everybody's heard of Plavix, there's other brands as well. So you have platelets and they're sticky, right? They're like Velcro. So the aspirin and Plavix help stop them being so sticky, okay? So then they won't stick in that clot and cause the heart attack to become even worse. Well, morphine has been shown in some more recent literature that's come out decreases how well aspirin and Plavix does that. So we're counteracting what we're trying to do, right? So not good. So what else can we use besides morphine? Fentanyl, right? We have fentanyl. So fentanyl's good for pain, right? So the other good thing is it doesn't seem to interact with the aspirin and the Plavix, which is the big problem in the morphine. And as you know, we can also give it intranasally, but hopefully most of the time if we have somebody who really suspects an ACS, we've got an IV. What else? y'all know about fentanyl. I don't think I need to go much detail on how to give that. All right, case, you're going to present the case. So we're going to show the protocol right at the end, and that'll have our actual dosing and stuff. But essentially, we're going to stop giving morphine for chest pain. Chest pain, we give nitro. Continued pain, we'll give fentanyl instead. Pretty simple, right? Everybody kind of understand why? It's not a huge, the literature is not just, it's malpractice if you continue to give morphine. There was a number of talks at Eagles about this. I can tell you I've changed my practice in the emergency department. If they have chest pain, continued chest pain, and I've given nitro, I'm not giving them morphine, I'm giving them fentanyl. And that's kind of the bandwagon that's rolling through that everybody's jumping on. So we'll see how it goes long term. But like I said, those studies, it's fighting with the other medicines we're given, and we know that that's what's helping us, that aspirin and Plavix. I'll let you talk about this.
Okay. So let me talk about it real quick. Before this protocol goes into place, we got to get everybody through this CE. So it's going to take me about 30 days. That's how long they get to watch the video. And then we'll send out the protocol by email and send out a letter that it is in place. Okay. So for now, continue with the protocol as is, or what do you want to do?
Well, but still, I mean, why could you just not call that pain control? I mean, nobody's going to get in trouble if they give fentanyl to a chest patient.
Okay, so as long as you've been through this class right now, you got some, y'all are educated. Right. Okay, as they see it, we'll get it done. I think I just stepped in a hornet's nest, but it's okay. We're good. All right, so let's talk about our report of the month, because it's a chest pain call. This medic is traditionally writing just incredible reports. So the story goes, this cat gets out of the hospital, but he leaves AMA. They put a stent in. He was having chest pain, and then somebody came in and told him in the unit that his wife was having an affair at home, so he left AMA and went home to check on her. Okay? You can't make this crap up. I'm telling you. EMS. You can't make it up. So they get on scene. He's having anterior top chest pain that's not radiating. Excuse me, guys, I'm sorry. He's normally on home oxygen, and he hasn't been on it in the last 2 hours since he's been home and found whatever he found, which that didn't get documented, which I was a little upset because I didn't know how the days of our lives worked out. But that's okay. The patient had no really other further complaints. He does a great job talking about the history. Once again, that he's been in the hospital. He had a heart attack probably 2.5 weeks ago. He's been in the hospital for a while. He talks about his allergies, talks about the medications, and thoroughly describes that the patient can't tell me what's going on. Gets him in the back of the truck. Is very thorough, once again, talking about the respirations, talking about this cardiac style chest pain. Visual and physical assessment shows nothing significant. The patient has got mild achy pain and just really describes it very well. States that he's equal presentation and fall with each breath. He does a great job here. Breaks it on down and talks about now we got him on the stretcher. He no longer really complains of any more no respiratory stress is noted, and that he's feeling a reduction in his chest pain at this time. Now, one of the key factors is this medic was very aggressive with this patient because the fact of what? He just got stents placed. So you know he had a cardiac issue. So what do you know about the 12 lead? It could be an old, could be new. What was different from the other day? Well, I don't have the ability to get in the power chart in the back of the ambulance and go, oh yeah, there it is from the other day and here it is now. I don't have that ability, so I got to make decisions. Once again, no new complaints. Does a great job, once again, documenting everything that he sees. Get to the vital signs. Very aggressive with talking about his pain management, his what is the pain scale, a nice trend he's showing. He's got his blood pressures, very thorough with documenting, and then reiterates once again that it's almost a 0 on a pain scale of 1 to 10. He does document a 1, which is not a 0, and so he's done a very good job with that. At the same time, he follows up, he gets the cardiac monitor on, tells us exactly what he saw on the cardiac monitor, gets oxygen on, gets aspirin on. What could be the cause of this chest pain? He just had stents.
And stress.
Okay, and stress, so it could be spasm, it could be another MI. We don't know. So, and it doesn't really matter to us at the end of the day, but then he breaks down his 12 lead very nicely. It describes exactly what he's seeing here, making sure to take out what the automated portion of that is. It does a very, very nice job, and it was redone and transmitted. Just a fabulous job documenting. Gets an IV, gets a blood draw, gets nitro on board. Also continues with another 12 lead nitro, another 12 lead, kind of a little OCD with the 12 lead, but that's good. There's nothing wrong with that. We'll take it anytime. And then kind of sums everything up. You know, they secured the rails with no complications, transported to the hospital 31-1, because he really doesn't know, is this new, is this old, what are we going to do? And then has some additional notes in here, but does a fabulous job. So here's his 12 lead right here. He saw. So guys, what are we seeing after we learned tonight? What is that? That could be that hyperacute T wave. You know, you're not really ST segment, but it's questionable at that point. But we really don't know what's new, what's old. So he's very aggressive with the way he teaches. As we know, this is pretty much worthless to us most of the time in the field. And there's this follow-up, one of the serial 12 leads. So you can see that's pretty much the upside down mirror image here. Really not a lot of changes, a little bit cleaner 12 lead though. And so the patient outcome was he gets to the hospital, his troponin was elevated to 1.53, normal should be 0.04. Well, what did Dr. Troutman say about troponin? It may take some time. So is this new, is this old? I don't know. I would probably guess it's from his previous MI, still kind of hanging around. Keep in mind that any time that there's any cardiac trauma or cardiac surgery, there's going to be elevation in troponin over time. It's just part of that. And also, like Dr. Troutman said, renal stuff can cause you to retrain some of the troponin that you normally tee off. The patient was taken back to the cath lab. No vessel occlusion was shown, but he was diagnosed with coronary artery disease. Really? But anyway, we got that. And then he left AMA the next morning again. So we didn't transport him after that. But for this month, we have Tucker Woody. Congratulations on Report of the Month. And for you, because I understand you're a guitar guy, so we have it to the Guitar Center here in Lotus. And you were already on file there. They had it under your name also, in case you lose your gift card. So obviously you shop there from time to time.
Oh, I have to go back one.
Sorry.
So I'll make a few comments on this. So how far out was he? Like 1 week? Or not even that from his, when he had his stent?
Yeah.
It's like two
days.
Like just a few days. So you guys see a lot of people in the field, they're on Plavix, right? Why are they on Plavix? Because they have a stent. Okay, so anytime we have a foreign body in the body, so everybody, I don't know if you've seen a spring, it essentially looks like a little spring. So you put a spring up into the heart to try to open up that vessel so the blood can flow through it nicely. If you just put that in and you go home, what's your body going to do? It's going to fight it, it's going to build clot there, it's going to do what? It's going to clot off in a few days, right? That's what Plavix is hugely important. Now they've tried to develop, like you'll hear the drug-eluting stents, and I think they're kind of out of favor. It's kind of a great idea, especially for people non-compliant. Just put the Plavix into the stent or put something, I don't know what was in those, to try to make it where the body doesn't fight those, to where when people can't afford their Plavix or just don't take it for whatever reason, they don't have this problem. So probably that's what happened to this guy. You know, he's 2 or 3 days out from the stent. He just left AMA. They might have, I'm sure they probably threw him, well, please take this Plavix, but he didn't care about that most likely. And then a few days later, he's got chest pain again. So the troponin, I mean, to me, this is meaningless. So that stays elevated a good 7 or 8 days after a heart attack, sometimes even up to a couple weeks if you really have a big heart attack and that number gets really high. So I mean, 1.5, that's meaningless. Yeah, that tells us maybe something's going on today, or maybe this is left over from prior. But they probably took him to the cath lab for that reason. He probably didn't take his Plavix. Now he was several days out, And so there's a high chance that he had another clot, but I guess it sounds like he didn't. So anyways, but good report. So the take home. So chest pain. Who in here has not seen chest pain, right? Big complaint. That's one of the top 5 that we encounter in emergency medicine. It's also the highest risk. In emergency medicine, the most payouts malpractice-wise are because of chest pain. And the most common of those are missed dissections and missed ACS. So whenever we see that patient and we discharge them and they go home and they have the big one the next day, or they are found dead because they had a heart attack and we missed it. So very important. So we always have to take it seriously. So who in here has seen 20-year-olds with acute MIs with STEMI? I mean, everybody has. It happens. It's hard to believe it happens. And it happens when you least expect it. But 20-year-olds have ST elevation MIs. It's low risk, but it's still a risk. 62-year-old, and you'll see this, the nurse will come hand you a chart. He's 62, he says his chest hurts, but I pushed on it. He's in there like saying, oh, don't push on it, that makes it hurt worse. That guy, again, maybe it's low risk. He's still pretty high risk, though, just his age. Just because it's palpable, causes the pain, that doesn't rule it out. You know, what about somebody saying, oh, you know, I'm 70 years old and I've got diabetes and I think it's just heartburn. Those are the ones that really bite you, because you're like, yeah, give him some Nexium and get his butt out of here. Well, that was the MI that you just missed. So very important, lots of ways that it can present. So of course, we talk about chest pain, and the blunt of this was ACS, but remember the other things that can happen that are emergencies. Dissection is a big one that sometimes can be hard to diagnose, but remember the real typical presentation is that really bad chest pain kind of radiating up to the back or between the shoulder blades. Pneumothorax, that can present as well, obviously with chest pain, and we know about that, decreased breath sounds, low oxygen sats. I didn't mention pulmonary embolism on here. That's another really big one. People die from PEs. You can be 19-year-old, a young female on birth control, can get a big old PE. They can have some undiagnosed protein S or C, I forget which one of those, will be young people that'll end up with DVTs and PEs and can die from that. Ruptured esophagus, another one that can happen. So, acute coronary syndrome, keep in mind that women especially, and it's not just women, men can too, but especially women that are diabetics, those are the classic ones. They never present like they're supposed to. Those are the ones that are probably going to have the GERD, or say my right hand kind of hurts, or their right face hurts and they're having a big old STEMI. Young people, family history is real important. Whenever I see a young person, it's always important for family history. When I've got a young person, they're 29, they say, yeah, my dad, he had a heart attack like in his 30s. So that's important. Cocaine use, we mentioned that briefly earlier. That's another big one that causes MIs sometimes. And, the classic, the one you learn in medical school, radiating the left arm, diaphoresis, nausea. I mean, that happens how often? Like almost never. I never see anybody with all those, when they have all those complaints, it's never ACS, right? It's always something else. They're usually anxiety or something. But it sometimes happens that way, but usually not. So, what's the biggest things that's going to make a change in outcomes in the STEMI? So we talked about it. You get that plaque, and it's actually, we didn't go into all the details, but the plaque ruptures and forms a clot. That's what actually acutely occludes that vessel. So what do we need to do? We need to get that open, right? So nitroglycerin does that. Just that little bit of opening of those vessels just allows a few more of those little red blood cells to scoot through there. That's a little more oxygenation downstream. Aspirin, stop that clot from getting bigger, maybe even of it kind of loosen up a little bit, allow some more blood flow. But the big thing they need is a cath lab. And hospitals get penalized if they're not in the cath lab from the time they hit the door to 90 minutes, they got to have a balloon up. 90 minutes, y'all probably heard that. There has been talk about, will that ever start at a 911 call? That would certainly change some things. If at 911 call we now have 90 minutes, and if the hospital doesn't meet that, they lose money. We'll see if it ever comes to that. So just remember, aspirin, nitro, really life-saving. I didn't throw oxygen in here, I probably should have. That's very important too for these folks. Early recognition of it, transmitting the EKGs. I mean, some of you in here probably can remember when we didn't transmit EKGs, but that's huge. Sometimes I'm sure you hit that send button and think, why the heck am I doing this? Nobody even looks at this crap. I assure you, we look at it. It gets
And the cardiologists, all of them have it on their phone.
Right, so we have the availability. So, so you send an EKG, and so we get it. Just like sometimes it's like, yeah, this is a big stinking ST elevation issue. You can show it to the student with you, and they go, oh yeah, that's just like in the book Heart Attack, right? But there's those others that you're kind of, well, sometimes we're a little as well, right? So we've got now the availability, we can actually have the cardiologist view it. So we can, hey, cardiologist, I'm forwarding you this EKG. I'm leaning towards we should activate this, but before I send the missile off, you take a final look at it. And then they'll make that decision with us. So that's helpful, and that took us like 2 years to make happen. And now they love it, because now even like the big honking MIs are, well, send me the EKG, I want to just look at it. So now they like it, of course. So morphine we already talked about, going away, start using fentanyl. And like I said, I know we need to go through maybe a little more official CE, but I mean, they're having chest pain, use a pain protocol and give them fentanyl. Nobody's going to get in trouble if they give fentanyl. Nobody's going to get in trouble for a little while if they're giving some morphine on the chest pains, but let's go to fentanyl. So obviously pretty straightforward change. It's OR anyways. What? Is this on the old one? Yeah.
Yes.
So yeah, there's no. So
It's more than orfentanyl.
Yeah.
That's why I'm saying it's in there.
In case you didn't have blood pressure, gives you a way to.
Yeah. So stop using morphine. It's just crossed off and over here now. All right. Any questions on that? So.